pretty much just recently got off and just still working at the hospital, so I do have a little bit input on remdesivir use. How about you, Vunami?
So I work at the Children's Hospital of Philadelphia, and as a pharmacy technician, I draw remdesivir from time to time. But within my 8-hour shifts, I only see remdesivir get drawn up maybe once or twice recently. But before, it used to be pretty often, maybe like four times. Yeah, and that's pretty much it.
What year are you?
I am a second year pharmacy student, and so I work in the Children's Hospital of Philadelphia in the IV department as an intern or technician.
Awesome. Well, glad to have you have some early experience in the hospital to be able to draw up remdesivir too. That might pique your interest a bit.
Yeah,
How
absolutely.
about everyone else? Anyone else want to introduce themselves before we start?
Anyone else? Ada, do you have a microphone?
Or maybe they're just listening in. Okay. I guess I'll get started. Again, this is one of our first journal clubs, so don't judge me if it doesn't go the way that we all planned. But I was just hoping we get a discussion off of one of the biggest thing affecting us this year, which is obviously COVID. I hope y'all are staying safe, and if available, you're able to get your shot, which I'm able to on last Monday. But let's just start off and just go over pretty much the journal that we're gonna go over today, which is the remdesivir for the treatment of COVID-19. It's the final report of the ACTT-1 trial, um, which they did release like a preliminary report before they decided to release the final one. And a couple of disclaimer: the views and opinions are those of the individuals, and it does not represent any of the institution at which we practice. So today, be free to share your views and your opinions. It is an open forum, and again, we're here to learn. And mostly, what I want to take out this is that we get we were able to engage most of the students and the non-pharmacists. That way, we get them earlier engage in journal clubs and pretty much establish like an online routine of journal club review, which is the goal and objective of this. I would say this journal club that me and Vunami kind of started. And of course, learn and share ideas. I know that there's probably other clinicians out there, and hopefully they could join this journal club or maybe future journal clubs. Hopefully we could get like specialized clinicians like ID pharmacists, or even pharmacists with PhDs, or possibly people that have experience in microbiology or biology, give inputs on topics like these.
And I just want to mention that, this is not CE accredited and that this event will be recorded for non attendees. So whenever you ask a question, you can, first introduce yourself as either physician, pharmacist, pharmacy student, but also, not only can you just ask the question in voice chat, but you can just ask in the chat box, the journal club chat. All right. And Fred board certified person asked any conflicts of interest though.
Yes, I am the CEO of Pfizer. No, I'm just kidding. I declare no conflict of interest. Anyone else here? Yeah. So yeah, pretty much. Currently, I'm working mostly as like integrated slash staff pharmacist at different hospitals. So I'm not really in industry at all right now. Again, if you just joined, my name is Steven. I'm a pharmacist in at Texas Memorial Hermann Hospitals. And with me today is Vunami, and he is a P2, and he's also currently an intern slash technician at hospital. So if you could introduce yourself today before we go straight to the article, which we will after this, that would be great.
Happiness, do you want to introduce yourself? Or if anyone
Okay.
wants to introduce themselves, feel free to do so right now before we get started.
Okay. Well, we're gonna get started, and hopefully we get much more input than just me and Vunami. I'm hoping that we'll get as much input as possible from the non-pharmacists. Okay. So let's get started on why this trial even started. So um, I did post out a template pretty much on how I'm gonna go down the things that we will talk about. So it's pretty much very simple. So it could be really short or it could be really long depending on how many people participate. So let's go down the topic of the hypothesis and the objective of this trial. Can anyone explain why they will even do something like this? Like, what is the biological plausibility of remdesivir? How does it work? Um, can anyone answer? Put this screen over here so I can see. So pretty much, remdesivir, uh, it's a inhibitor of the RNA virus we now know today as the coronavirus, the COVID-2. There's multiple coronavirus out there. If you have read do the different types in the past, there's the MERS, which is the Middle Eastern virus, and then there's also the SARS virus that came out from Asia, um, and pretty much remdesivir works as an inhibitor of the RNA polymerase, which inhibits the replication of the virus within the cell. So there's a biological plausibility to this, and there's a reason why they decided to do this trial, because remdesivir is one of the more promising agents that can give substantial improvement to these patients, which at this time we didn't really have much to go off of. We didn't even know about dexamethasone use or even anticoagulant use. Um, what's the problem though with thinking about that? Like, what's the problem with just sticking with biological plausibility? Vunami, do you know of any problems with that?
And sorry, I didn't I didn't catch that. Sorry, I was getting a message. Can you ask me the question again?
Yeah. So what uh, we know something works like scientifically, like if we have tested like in vitro, for example, remdesivir. What's the problem with just doing that?
If it's in vitro, then we wouldn't have enough evidence on for individual use of remdesivir, considering its mechanism of action, and also in regards to long-term effects. It's not something we have enough information on. So having further studies is necessary.
Yeah, that's correct. As this trial was started, as they were starting to enroll people, there was no substantial clinical evidence that remdesivir actually works. There's some evidence that in vitro it works when you inject it into cells or when you inject it into monkeys. Um, there was some evidence that it works, but there wasn't actual substantial clinical evidence that it actually works. So this is one the I wouldn't say landmark, but one of the starting trials that show that remdesivir could possibly work. Now, the reason why you can't just stick with biological plausibility is think about what was you remember the other agent that was introduced, Unami? I'm pretty sure everyone knows.
The hydroxychloroquine.
Yeah,
Yes.
exactly. Yeah, that agent was introduced, and pretty much it was really small sample study that they did, and they were really it was more like a correlation versus causation kind of thing. And even though hydroxychloroquine, there is some biological plausibility that it might block the entrance of the virus, or potentially be also a zinc ionophore, which can increase the amount of zinc into your cells and block viral replication. All that was possibly seen in vitro, but clinical evidence showed that it actually didn't really work. So the study design of this was pretty much anyone who was enrolled was 18 years and up, and they had uh, uh, they had to have like a positive test of the SARS COVID-2. Um, and the third thing was that they have to have symptoms. So they had to have the new onset of symptoms such as cough, loss of smell, fever, possible shortness of breath. Um, any opinions about how this population was chosen, or do you have anything that you might want to add onto this? Okay. So the design of the study is pretty much a placebo-controlled trial. It was randomized, so they randomized it 1 to 1, and pretty much they did it over 60 sites across the globe, mostly in the Americas. And the placebo either had like an actual placebo where you'll be injecting like a non-active drug into a normal saline bag. However, they did run out of that in certain countries, so they had to have like a blinded normal saline bag just being infused. So that's one of the limitations of the study design. And uh, I guess moving forward, that might be something that you might think of. Um, but pretty much this is the amount of people they enrolled. Um, and only 52 were excluded, so it wasn't that there were many that were excluded. Most of them didn't meet the inclusion criteria, and then some of them were just not enrolled. So a total of 541 were assigned to receive remdesivir and 521 to receive the placebo. And pretty much not all of them received the 10 doses. So the intervention, they had a loading dose of 200 milligram, push not push but infused intravenously, and then 100 milligrams thereafter for the last 9 days. And then here is not all of them received the 10 doses, and then some of them were discontinued due to adverse event, which we'll talk about later. Same thing with the placebo. Not all of them received 10 doses of placebo. Some of them were discontinued due to adverse event, which is kind of funny. If you notice from these two, the adverse event is kind of similar, which is funny because that's not something you would see most of the time. You would see the intervention group probably have more adverse event due to the drug. Um, so 517 completed the study, 508 in the placebo. However, again, there were exclusions. There were people that died, and 541 were treated as intention to treat, and 521 were treated as intention to treat the placebo. Vunami, do you know what intention to treat is?
Intention to treat. Um, you know, a thought crossed my mind. Not sure.
So you notice 541 were originally assigned. However, when you go all the way down, you start seeing some really weird things happening, like either dying or they missed doses, or they were withdrawn, or they were transferred to another hospital. And then in the placebo group, you can see that there's some protocol deviation, and some of them were probably transferred into the remdesivir group, which I think I saw somewhere. Um,
So, would you consider this a modified intention to treat, given that, or were there any sort of indications in how they dealt with missing data?
um, I'm not sure what your question is. So you said, would I consider the 541 versus 521 the modified intention to treat?
No, in terms of like who they actually included in their analysis, because we do see some variations into how many people based on um, the number of people who are randomized versus the number of people who were actually included in the statistical analysis. There were some discrepancies there,
I would
and it wasn't
say in
really
the
clear to me in my reading of the article what they did with the missing data, if there was any. Granted, I didn't really take a hard look at the supplemental information.
which is fine. I think they went full ITT on most of the data, and I would say the modify is when they start going into like subgroup analysis, which we'll go over later.
Okay, and did we already talk about the demographic information? Our
Oh
table?
no,
Okay,
no, we haven't.
okay.
Uh,
I'll wait
uh,
until we get that in.
how about you also introduce yourself?
Hi, yeah, sorry, Crimson Five here. I just got out of a thing with my rotation, so I thought I'd just hop in because I've done this article before in previous journal clubs, and I'm just curious to see how everything's going on.
Okay, awesome. Are you a P4 or are you a
Yeah,
P3?
P4 right now, currently on rotation at a at my school's drug information center. So this is kind
Okay,
of my bread and butter every day.
nice, nice. Well, glad to have you, and hopefully you can also contribute
Yeah.
to the information here.
Thanks for coming in, Kristen.
Yeah. So right now we're just talking about pretty much the randomization and going all the way down, and what is being included in the intention to treat population, which I was explaining to Runami how obviously there were funny things that happened in between who were randomized, and also up to the point where they ended the surveillance, and they included which one who is to be included in the intention to treat. So they decided to include like the 541 initially, and same here they decided to include 521 initially, and down here are the per protocol treatment. So these are the one they excluded, and they did an analysis per protocol. However, when I look in the supplementary, I didn't really see much analysis on this, unless you guys can correct me later.
So, intended to treat, the idea is very self explanatory, meaning that I guess if it's 541 individuals in the study and 541s are included in the intended to treat population, it's just that they are all put into consideration for the treatment of remdesivir.
Yeah, they intended to be treated with remdesivir. So even if somehow they got placebo or they drop off due to some random reason, they're gonna be included in the final statistical analysis, and that way it can minimize the bias.
All right, thanks.
No problem. Okay, now we're gonna move to the baseline characteristics. So again, this is remdesivir, and we're treating COVID, right? So what do you think you should watch out for in terms of the two groups, the placebo and the remdesivir group? What should you watch out for that you want to make sure are not completely different from each other?
For me, anytime I review an article, you'll want to see um, good correlation between the experimental and control group to kind of eliminate any sort of biases or um, weird things going on between how many people we're treating to make sure that we're able to generalize the results later on once the analysis is done.
Exactly. You want to see you want to make sure that there's no wide differences between the two groups. But specifically to coronavirus, what have y'all noticed? I mean, just by watching the news, and uh, hopefully, you don't have anyone in within your circles that have been affected terribly by this virus. But what is some of the risk factors that you see with COVID patients?
In terms of risk factors, are you talking about concomitant conditions or something else?
Yeah, like comorbidities, or something that you see that could lead to like severity, increased severity of disease. So what I mean, we could start off by talking about uh, uh, what do we look out for when we get coronavirus, right? Those are some simple ones. Like what symptoms do you watch out for?
Fevers, coughs, shortness of breath.
hmm Where do you think the virus go? Like where does the infect? What screening do we look at when a patient arrives into the hospital?
The upper respiratory site.
Yeah, and also the lungs. I mean,
Yeah.
also the lower respiratory site, lesions with the lungs. So you want to look for those things, like comorbidities if they have any lung problems or anything like that. However, um, COVID is a funny virus. If you notice, there's other comorbidities that are actually, from what I've seen, huge risk factors to the severity of the disease. What do you think those are?
Some of the respiratory disease like COPD, asthma, and the like.
Yes. So what I mean, other than respiratory, what do you think? What have
Maybe
you seen?
perhaps diabetes, patients with diabetes,
Diabetes.
or history of
Yep.
pneumonia, maybe anticoagulation issues.
Exactly. Yeah. So you speak of anticoagulation, diabetes. So pretty much those lead back to cardiovascular issues. What I've noticed from my experience so far is obesity. Right, obesity is one of the big risk factors to the severity of your disease with COVID, and it's because now they realize that COVID is not just a respiratory virus, but it affects your cardiovascular system. It increases your inflammation within your body, and that can increase to clotting. That could increase to um, circulation problems. So it might not just be your lungs that are failing you, but your overall circulation problems. So obesity, diabetes, cardiovascular. Those are the things I would look out for when I'm reading an article like this, based off of my experience, whether or not those are different between the two groups. And the other thing is admission. When they were admitted, you want to see how severe they were when they were admitted. Were they on oxygen? Uh, how bad were their saturation? Were they already mechanically ventilated? So those are the things you want to see when you look at the baseline characteristics of the group. So I'm going to pull up the baseline characteristics and pretty much miss something else, right? If you notice age, right? That's a big factor. That's a big risk factor that we also talk about, and we hear in the news all the time. So when you're looking at baseline characteristics, and you look at this article, you notice that it's pretty well balanced, I would say, except for a few key things. So as far as age, it's pretty well balanced. The race or ethnic group, that's something that you might look into if you think that might affect different people with different genetics or possibly different areas of social economic. But generally, I don't look at this unless there's like some real key factors that show that there's a big risk in like the Asian population or the American Indian or the white population. Um, the thing I notice is the comorbidity. So you notice it's pretty well balanced between the two, either having one or two or more. And then right here is what I'm talking about: cardiovascular and obesity. So those are the things I would look for. If they are different between the two groups, then that's something that you have to keep in mind by the end of the article, and that's something that you have to determine whether or not to believe in the internal consistency of the analysis. So obesity is 45% and 45%, so it's about the same, and hypertension is also about the same. Type 2 diabetes is also about the same, so I'm not too worried about this. Now, they did list other additional comorbidities in the supplemental, but they didn't pull them out because they were about the same. So the last thing I mentioned was the pretty much how the patients look like when they were accepted, right? So were they on oxygen? Were they not on oxygen? Did they require a higher form of ventilation, such as a non-invasive ventilation or high-flow oxygen device, or did they immediately needed a mechanical ventilation or ECMO? So this is the thing you have to also look out for as far as the baseline characteristics. And one of the thing to notice here is that mechanical ventilation was more in the placebo group than it is in the remdesivir group. Can anyone explain how that might affect the results?
categorizing the severity of the illness, probably.
I'm sorry.
Sorry if y'all can't hear me. Categorizing like the severity of the illness.
Yeah, and if you notice, like in the placebo arm, if it's more severe than in the treatment arm, what, how you think this either strengthen or weaken the conclusion?
You have a higher risk of making a type 1 error. Or is it type 2? Let's get those confused.
It's type 2.
Type 2.
So yeah, type 2 is like a false negative. Um, so which isn't completely bad, right? If you think about it, if it, that might be a strength in itself. So if you have like more severe patients in the placebo, but somehow the treatment arm is improving better overall when you look at the intention to treat population, which doesn't pick and choose, then you can say that that's actually a strength to the clinical trial.
I did have a thing on the use of an ordinal scale for this because there is some level of subjectivity, especially when you look at between categories 4 and 5. How does one decide who needs oxygen and who doesn't? And because this is like a large multinational, multi-center trial, there could have been a lot of discrepancy in terms of provider um, decision making in terms of who goes into what category.
Yes, I totally agree with that. That's a good point that you brought out. I did see that too. Between 4 and 5 is kind of very subjective. However, 6 and 7 are not. 6 and 7, like 7 is like you're almost like if you don't have any machine that is pretty much controlling your lungs or your circulation, you're pretty much dead. So 6 and 7 are not, but you're right about 4 and 5. How that might affect the results, that's something that we'll look at later. But good point.
And do you also have any thoughts about the terms of population? There was a high number of people who were categorized as white, and very few, like almost half, for the other one. So, do you think this will affect the generalizability of the results for Remdesivir?
Like I said again, I focus mostly on race. If there's like some genetic component that might affect the treatment, which currently we don't really have much data to support. Um, but I mean that's always those are always valid points until somebody finds out like a actual not just like a correlation, but a causation, then I would worry more about it. But what I look at when it comes to race, if we don't know that one race is more affected than the other, what I looked at is at least a balance in between them. So you notice 53% whites in the I mean 51% in the remdesivir, 55% the placebo. That's really not that much different. And same here, 20% and 22% for the African American or the black. And then Asians are also, they're not that much different. So that's what I would look for if there's not really like a straight up answer to whether or not race really affects the outcome of the study. And then later on, you can see too that they broke it down into like forest plots, and they try to show that whether or not each race have a different outcome. And in my opinion, some have a statistically different outcome, but they're all leaning towards the use of remdesivir. Does that make sense?
Mm-hmm.
Okay. So those are things you watch out for when it comes to remdesivir trial. So any pretty much any trial that deals with COVID in the future, if you guys are going to read on it, make sure you focus on again the risk factors, how the patients come in. Again, any imbalances in those demographics should be taken consider. Here's the funny part: the primary endpoint. And Crimson, you said you read this article, your hospital tore it apart. Uh, so can you speak a little bit about the primary endpoint of the article?
Sure. Yeah, so it was basically time to recovery. Um, as far as primary outcome, from what I remember, I haven't looked at this in a while, so feel free to just kind of uh, jump in
Yeah,
there.
that's right.
but it was just improve. And I think the secondary. Oh, wait, I mean, I'll just stick with the primary at this point. It was just, yeah, I think it was time to recovery, wasn't it?
It is, yeah. So it's pretty much time to recovery from day 0 to day 29, and they plotted using a Kaplan-Meier curve. So yeah, that's right. But do you remember initially what it was? Like what they intended to use as the primary outcome before they changed it?
Wasn't it a shorter time frame rather than the 29 days?
Yes. So initially it was from 0 to 15 days, and it wasn't time to recovery. They were trying to look at whether or not there was an improvement in the ordinal score.
Mhm.
So um, with primary endpoints like that, it's typically primary endpoints with ordinal scale score, like you said, there's some subjectivity to it. So this change in the primary endpoint, what are your opinions on it?
It was really hard to say because when we looked at this article, it was really early on, kind of in COVID. So seeing that there was potentially an improvement, just kind of just looking
Yeah.
based on the Kaplan-Meier plots, and it was really only significant for those who were receiving oxygen.
Yeah, so we'll go over that. I definitely agree with the change. If you look at the template I sent out, the one of my favorite primary endpoint is like total mortality or something related to that, because you can either die or you don't die, right? But you go off ordinal scale scores, something like I don't know if y'all have read the like the NINS trial for alteplase for stroke, or something like that. When you have an endpoint where it deals with scores, and you have like a statistical significance between the two scores, for me it gets a bit fishy. Like you say, it could be a bit subjective, and also it's harder to generalize towards the overall population. So I'm actually glad they changed it, because they realized that the course of coronavirus doesn't just involve the viral phase where it replicates and it infects your lungs, but there's also a secondary course to the virus, which is the inflammatory phase. So it goes beyond just 15 days for a lot of people. Okay, so now we're gonna go pretty much over the results of the trial. So Crimson, you mentioned. Let me try to zoom this out. So I guess we could first explain the Kaplan-Meier plot. In Crimson, I don't know if you have learned in your rotation, but can you explain the plots starting from A, um, and just like any details you see with the
Yeah,
plot?
sure. So basically, this right here is a Kaplan-Meier plot, and just to not get in the weeds, it's a good way to visually represent the data to determine whether there is a difference or not between your experimental and control group. The farther apart the lines are, shows that there is a difference, or there's at least a separation between the two arms of the trial, and kind of what we see, like within D. Um, when things start to cross over a little bit, we see less significance in the statistics. So if we start with A, this is the overall um, results from everyone who they had in their trial. So as we can see here, there's a little bit of a separation between the placebo group and the experimental remdesivir group, which kind of talks a little bit about that they're seeing a higher amount of people recover at X amount of days, as you see in the x-axis right there. And if you look toward the bottom with the number at risk, you'll see that as time goes on, there were less people at risk, meaning more people recovered. So when we look at the numbers, the 541 versus the 521 at day 0, that would be who they randomized at day 0. And as time goes on, they saw less and less people have that risk, which meaning more people recovered. If we go ahead and go to B for patients not receiving oxygen, what you'll see is there is a little bit of separation in the line, but the shading refers to that 95% like confidence interval. So there's less of a confidence that we see a difference on there, even though visually we do see it. But if you look at the numbers again, because of the population size, it's less likely for us to be really confident that there was a statistical significance in there. In comparison to C, we do see a separation as well as a shading, which represents that um, statistical significance. And then uh, keep in mind here, I'm talking about statistical significance and not clinical significance. So, and then when we go with D, it just goes over the other subgroups um, that were pretty much studied. So, with the B, C, and D, those correlate to our 4, 5, 6, and 7 groups.
That's a really good explanation. Thanks for that, Crimson. So I would like to add, besides what Crimson said, so for the people dropping off, it's not just people that recover, but it's also people that have died, and it's also the people that pretty much drop off due to other unexpected circumstances. So whatever is left is the remainder that they analyzed on that day that are still at risk, and they use this to calculate the proportion recovered cumulatively up to day 28. Um, and then I'm really glad you brought out the confidence interval and also how the sample size affects it, because that's something that it's really good to mention, because if you notice for the patients receiving oxygen, this is the bulk of the group, right? This is like half of the group, and that's why the confidence interval is a little bit smaller, and that's why you can say that this is more statistically significant than the other groups. And then, so pretty much the people that were on high flow oxygen, non-invasive, pretty much people on category 6 and category 7 who's on mechanical ventilation or ECMO, there was no perceived differences between the two groups. So that's the results, the primary results. And then when we look at the secondary results, I gotta flip this. So the secondary results deals with mortality due day 14, which is one of the original secondary results that they published, and then they did day 29 when the final report came out. So Crimson, one last explanation, hopefully from you. Can you explain the hazard ratio for the overall mortality after day 29, and what does the interval in between those this mean?
Sure. So with a hazard ratio, we're looking at the likelihood we have an adverse event happening, whether it be death or an adverse effect. When things are equal, we expect this ratio to be 1, right? So top and bottom are going to be equal. When we see the less than 1, what we see here is a reduction in that hazard. So with a 0.73 hazard ratio, we're expecting a 27% decrease overall for that specific hazard. And it looks like just based on this chart here, we're looking at death. So if we kind of go off to the right here, like with the 6 and 7 categories, we see a hazard ratio of greater than 1. So with the 6 in particular, we're seeing a 2% increase in that hazard if we were to implement the intervention. So kind of a question to the group here. We see more people die in the 6 and 7 group. Do we think that is a consequence of the remdesivir or not? Because if you look at the numbers tell you that more people on remdesivir died if they were category 6 or 7 when given the remdesivir. I'm just bringing this up just for the clinical significance portion.
That's a good question. Can anyone answer that? What do you think about the hazard ratios being higher than 1 for group 6 and 7? or category 6 and 7, if you remember what those are. So pretty much, I can answer that question since nobody else is. Category 6, if you remember, that's like the higher intervention of oxygen, so non-invasive and high flow oxygen. Category 7 is pretty much the invasive methods of oxygenation, mechanical intubation or ECMO. And you can see here that not only are they greater than 1, but their confidence interval is between uh, uh, zero point 0.5 and like 1.91. So it's pretty much telling you that there's no benefit. Not that there is an increased amount of deaths statistically speaking, because if it there's an increased amount of deaths statistically, then you would have the interval greater than 1 from the left to the right, the 95% interval. So if you go over the overall, yes.
What we're talking about here is what's in the parentheses is the 95% confidence interval. And for ratios, we're looking at one being kind of the our marker for significance or not. So if this number or this range here crosses one, we can go ahead and assume that this is not statistically significant, even though it may have clinical significance. We can say that statistics wise, there is no significance in the data that is presented here.
Exactly, and that brings up a good point. So you look at the overall intention to treat, pretty much analysis of the hazard ratio, it does cross 1. So what can you say statistically about that, Crimson?
It's not statistically significant. So, I
Yep.
mean, there may be some clinical significance to this, but just based on like raw numbers, we can see it. But if we were to put pure statistics in this, the number doesn't really mean much to us.
Exactly. So to us, we're 95% confidence that it might land somewhere also on the no effect zone.
Yeah,
That's
so
what we're saying.
we can't confidently say that if you are put on remdesivir, that you have an increased chance of survival.
Exactly. With the overall group, that is.
Hmm.
Yes. However, when you bring out the clinical significance, you do see that it somehow leans to the side of not dying. So there could be some clinical significance there.
And honestly, this makes me kind of wonder about how they presented the data in terms of internal validity, because this was their primary endpoint up until they changed it.
Yes, so the primary endpoint was either mortality to day of 15 or I believe it was the change in the ordinal category scales. So it does fuzzle a little bit with the confidence of the internal validity because they did change it. However, they did decide to stick with these ordinal scales, and they did decide to look at mortality from the beginning. So it's not like something they did after the matter. It's not like a post hoc analysis where they decided, hey, these are funny numbers. Let's go back and dig up some more. So they did think it through a little bit, but yeah, it does fuzzle up pretty much the confidence a bit with the internal validity of this trial.
And also, kind of while we're on that note, did we already go over difference between types of data, ordinal, nominal, and continuous?
I guess we haven't, but if you want to go over them, that's something that you could briefly go over right now.
Sure. Yeah, and so they're using an ordinal scale here to categorize um, kind of the severity of disease. So when I think of ordinal data, I think of a rank. So it's ranking for, at least from least to worst here. In different studies, sometimes they use nominal data, which can be considered like a yes or no. It's like, did they recover or did they not? That's more of the nominal data. So when we look at number of recoveries, we can consider that nominal because you either did or you didn't. And in terms of continuous data, these are things that zero really has no significance value. So like temperature or weight, like you can have a a true zero in terms of change, things like that. So it just knowing the types of data that's being presented in the study really helps you understand and hopefully make some clinical decisions depending on how the data is presented.
Exactly. Yes. So the yes or no ones, especially when it comes to death, that's one the data I look forward to because it's less subjective. You're either dead or you're not. Same thing with recovery and discharge from hospitalization. So they did go over some of that, but they did added this ordinal scale, which again does add some subjectivity in terms of where you are placed initially on the scale.
Did you calculate any sort of number needed to harm at all or number needed to treat?
So
I mean, we couldn't do an NNT because we don't have any nominal data, but we could have
yeah,
potentially done an NNH based on the mortality.
yeah, we could potentially calculate that, um, but looking at like the Kaplan-Meier curve,
Mm-hmm.
you can't really do it over a Kaplan-Meier curve because it's over the amount of time.
Yeah.
Um, so there was not like an absolute like an absolute risk reduction or anything like that that I could see because they did it over time. Um, if they didn't do it over time, if if it was a straight up yes or no kind of data, then I would calculate the number needed to treat and the number needed to harm. But the thing about this trial, the thing that is so funny about it is how the subgroups are so different from each other. Um, and that's why for me, if I were to calculate that, it wouldn't mean anything for me at this time, since this is also very new information. Because look at the subgroups, right? If you notice patients not receiving oxygens, patient receiving oxygen, there's such a huge difference between that and also the mechanical ventilation. Um, for me at this time, what we should be doing is we should be discovering who actually really benefits from this, and when we target those people, what is the number needed to treat? But at this time, we don't have that data. Does that make sense?
Yeah. And thanks for the discussion. I just wanted to bring that up just because for future journal clubs, if everyone's wanting to present, that's kind of what we look for as pharmacists to help determine whether we should implement the intervention or not. So thanks for that.
Yes. Yeah, no problem. Thanks for bringing it up. Um, so I'll go over the pretty much the final secondary outcomes, which is the median time to improvement, which you can see here. It is a little bit shorter for one category of the ordinal scale and two category of the ordinal scales, um, for the remdesivir versus the placebo. And also here's the weight ratio where higher is better. Um, and then as far as hospitalization, you can also see a trend where it is shorter for the remdesivir group versus the placebo group. And here they did a difference with a percent confidence interval. So my question is, how do you interpret a difference confidence interval versus a rate that we've been talking about? So I guess I'll go over that since we're kind of running low on time. So with difference percentage, if it crosses zero, again zero meaning there's no difference. Same thing with a rate or a hazard crossing over one, which one means there's no difference. Then you could say it's not statistically significant. But as you can see here, the median duration of hospitalization is it doesn't cross over zero, so there is a statistical significance. The amount of days on oxygen is also statistically significant in the secondary endpoint, being lower in the remdesivir group versus the placebo group. And then also you see similar trends pretty much going down here, except when you go down to the pretty much the category 6 and category 7 patient that we've been talking about so much. You see zero here. There's no difference, and also the confidence interval crosses zero. Same thing here. It says -3 median days of mechanical ventilation, but again, it crosses zero. So as you go to the higher severity groups, you can see that there's no difference in treatment in terms of days on oxygens, days on the mechanical ventilation. Does that make sense?
Yeah, it can be stand to reason that their death potentially was more of a consequence of disease rather than the intervention, which is kind of why we see very little difference in the control versus experimental. So it helps us kind of form a picture in our head, who would benefit the most from the intervention.
Yes, yes, and before we get into that, which is pretty much anyone else with experience with the hospital criteria on remdesivir use, pretty much let's go over the consistency of the data. So was it internally consistent? Did you see a trend that we've been seeing here? What are your opinions on it?
It's kind of hard to say, just because this is a relatively novel approach to impacting survivability. And it's one of those things, though. The data for me personally is a little shaky on its benefits, but it's one of the only things that we have, and there is some evidence that it is somewhat effective, although um, it may not be impacting survivability. It does potentially help um, people in terms of recovery time, assuming they're not so far along in their disease state that it doesn't matter anymore.
Yeah, I totally agree with that. And from what you said, to me, yes, it is pretty much new data. And with any new treatment, you would expect pretty much the more severe cases to have the highest benefits, but not in in this journal, not in this data. So that might fuzzle up the internal consistency a bit, but because of everything else we've been seeing as far as just looking at the data with this trial, it is somewhat internally consistent. It is showing us that there's no effects with people at higher severity, which is something that maybe we could discover later, the reason behind that. But it does show that there are benefits for people on oxygen, and benefits, pretty much overall benefits. So internally, yes, there's some things you take out of it that might be not internally consistent, because again, like with increased severity, you would expect a benefit. But overall, when we're looking at primary and secondary endpoint, it kind of agrees, because we're seeing that the more severe cases are actually not benefiting. So compatibility with other trials, there's not much that has been published other than trials that does also show that it does decrease the median days when remdesivir is being used. So now I go back to the pretty much the subgroup analysis, which is what we've been talking about throughout the um, entire journal club. And a good way to pretty much look at the subgroup analysis is a force plot. So Crimson, can you explain a force plot real quick?
But what this is actually looking at is kind of what we've been talking about all along. So when we terms of a ratio, so we're looking here at the recovery rate ratio, and again, our kind of marker of efficacy or significance is that one. So what we're looking at is the dots on here. The dots are the actual data points that we have calculated and measured, and what the width of that line is at 95% confidence interval. So with any ratio, we want the line to either fall one way or another and not cross that one. So when we look at the all patients on there, we see that they calculate a point of 1.29 with a confidence interval of 1.12 to 1.49. They represented it here both numerically and graphically to show that there is significant data here that promotes the use of remdesivir being better for these patients. And then when we look down to the specific subgroups, Um, we see, like, particularly here with the geographic regions with Asia, we see a calculated point of that 1.36, but a very, very wide 95% confidence interval. And this is probably due to the fact that the number of patients is very low. So we have, with a low population size, we have a greater degree of variability um, in there. So the takeaway point on here is to see what the numbers are and kind of what they mean. That kind of makes
Good.
sense.
No, that was really good. So pretty much here's the subgroup analysis, and like Crimson said, depending on how many patients you have, it can affect the confidence interval because the more patients, the lower the range of the confidence interval. That's just how it's calculated. And then if the confidence interval happens to cross this dashed line right here, this 1.0, and again we talk about a ratio. If anything crosses that line, statistically there's no significance. So what this trial has is trying to show that there is statistical significance overall with all the patients that remdesivir is much better in terms of recovery rate. And then you go down the line. Asia, again, there's not that many patients, so the confidence interval is much wider. However, the calculated recovery ratio is on the remdesivir better side, which is it's trending to the right. Now, Crimson, you mentioned about race. So if you look at race, again, you notice that whites make up most of the population, uh, and that's therefore their confidence interval is shorter. But and they show a statistical benefit. But when you look at the other race, you can see that there's no statistical benefit. However, it does lean to remdesivir being better. Now, you cannot say that just because of this data that whites benefit more than black, Asian, and other. And the reason behind that is the fact that again, it just because there's no statistical significance doesn't mean there's no clinical significance. And given the fact that there's more whites in this population, that you were able to detect that statistical significance. Um, you want to add to that?
No, and just wanted to bring a point. I don't want to take up too much of your time, but it's more of like one of those things as pharmacists. We really have to be cognizant of the difference between clinical and statistical significance, though. Because if we do see a benefit, even though it's not necessarily statistically significant, because the numbers don't lie, but how we kind of use the numbers really determines kind of what we use coming from our clinical tool belt. And that's kind of all I had to say about that.
That's really good. Yeah, that's correct. I'm glad you brought it up because again, we really had to be careful about the way we use numbers in terms of clinical versus statistical, looking for clinical versus statistical significance. The last thing I want to bring out is the fact that again, when you look at the subgroup, the one that benefits the most is the one with oxygen, statistically significant. And also the fact that people with earlier symptoms of onset of symptoms also benefit statistically more than the other groups with statistical significance. So that and finally the side effects, I would say is the weakest point of this trial is probably the side effects. That's something you kind of had to dig into the supplementary and see what they listed as side effects. And if you look at what they listed as side effects, you wouldn't think they are side effects related to the drugs. So these are what they listed as the side effects. Uh, Pretty much metabolism disorders, psychiatric disorders, respiratory disorders, which is really funny because that's what we know coronavirus does. Also, the same thing with vascular disorders. As far as clotting, we know that the coronavirus adds to the amount of inflammatory markers in your body, and that can also lead to clots. Um, so, in my opinion, the biggest weakness of this trial is definitely the side effects. I know they don't have enough patients to even power the side effect that we mostly would like to look at when it comes to remdesivir treatment is either it affecting the kidney with glomerular filtration rate decreased, or AKI increases, or the increase in liver function tests. That's something that I want to look at for future articles. Uh, but pretty much they fuzzle up everything by adding all these side effects into pretty much one category of adverse events. And what kind of type error is that, Crimson? If you know.
Sorry, one more time. What was the question?
So what kind of type error if you add a bunch of factors into one category? If I were able to detect a difference between the side effects of one group to the other, but however the side effect groups has let's say like 20 categories in it, what kind of type error do you think will be affected?
False positives, that'd be a type 1 error.
Yeah, it'll be type 1 because you pretty much you're adding all these factors in, and if one factor becomes like the like let's say glomerular filtration is like 200 in this group, then pretty much you can say that all these side effects are statistically significantly greater than in this group than that group, just because of one factor, and that's a type 1 error, and that's something that I would say is the biggest the biggest downfall to this study, probably because they didn't know of all the side effects or adverse events that remdesivir can cause, so they pretty much listed everything here. I mean, it's kind of crazy. They even listed pneumonia, bacteremia, and all that as adverse events. But that's my opinion. I don't know if anyone wants to add to that or anything like that, or correct me if I'm wrong.
I mean, at least my kind of takeaway with the adverse events is that it wasn't really categorized as treatment emergent adverse events. They just listed it as the adverse events that they saw. So there's really not much in there for us to say that it was caused by the remdesivir.
Exactly. Yeah. But the good thing is that they pretty much didn't find much difference in between groups. Again, going back to what we discussed about the baseline characteristics, if we don't really know something can cause a difference in the outcomes, at least have it be the same in both groups. And in this case, it was pretty much similar down the line for the adverse events.
Kind of what we do at
So
my. Sorry, go ahead.
go ahead. Yeah, go ahead.
No. Well, I can say kind of what we do at my institution is that whenever we do a journal club, we develop an elevator pitch for whatever journal we're doing, because us as kind of the drug information resource for whoever needs to ask, will sometimes ask us like, hey, Leroy, what about this remdesivir trial? That what do you know about it? So if we can like come up with like a 5-minute elevator pitch just to really to give a good overview of the study itself, gives you a good indication whether you understand kind of what's going on with the trial. Because why we do journal club is less about going over the journal, but it's more critically analyzing the journal for our specific uses.
That's a good point. And with that, I would like pretty much for anyone who participated throughout the whole time to maybe give that elevator speech and any feedback you have from your institution. So pretty much I can start with that. From looking at this journal club, this ACT-1 trial, pretty much one of the first randomized trial that had a significant amount of patients in each arm. I see that there's more to learn, especially in terms of the symptoms of onset. There's more to learn about the virus. We know that, again, it's broken up now into two phases. It's not just a viral phase where it infects and causes damage to your lung, but there's actually an inflammation phase. So whether or not remdesivir, which part of the phase, where do we start remdesivir, is the most important to me. I noticed that when you look at the supplementary, the patients with the lowest amount of symptom onset of symptoms, like less than 6 days, those gain the most benefits. So as far as what I know, and from my institution, we only give remdesivir to patients, and we only do it for 5 days, not 10 days. We only give it to them if they come in with symptoms of onset of less than 10 days. But our preliminary analysis showed that there was no benefits. So for me, looking forward, I would think that we kind of had to decrease those amount of days, because I feel like what this trial has shown is that you had to hit it early, like as early as possible. So that's my elevator speech. I don't know if that's super long. But how about you, Crimson? Can you give yours and maybe Vunami and somebody else?
Sure, yeah. So mine, when I initially had this for Journal Club, is like the trial Remdesivir for treatment of COVID-19 was a multi-center, multinational, randomized placebo-controlled trial looking at their primary outcome being time to recovery in terms of days. Their initial primary endpoint was looking at mortality benefits, but that was moved to secondary based on kind of what they saw. And what we saw here was, in a nutshell, that really the only people who benefited from remdesivir treatment were those who were on oxygen and those who were um, early on in the progression of their disease. They did actually see some death, although not statistically significant, in the more severe groups in there. So my takeaway for this would be, if we were to use this, would be to limit the use for the people who required oxygen and potentially saving it for them since they saw the most efficacy, and look at other options in terms of treatment for those that are more severe. And that's kind of what I gave during mine.
That's really good, yeah, and that's I would add to that that's also part of my institution protocol, that you have to be on some kind of oxygen before we initiate remdesivir on you, besides the symptoms of onset. Vunami, do you have anything to add?
Not really. I mean, this is my first time hearing about this article in general, and having not read this, I think that I've been educated a lot about this in regards to this journal club. So thank you so much, everyone, for participating. Crimson, Pac-Manic Maniac. Yeah. So thanks a lot for hosting this, and I see that we have some physicians, pharmacists here. So thank you for coming in. It's been very insightful. So thanks a lot for hosting this again, Pac Maniac.
Oh, no problem. I really enjoy doing these things. That's why I decided to do it. And hopefully we could get a routine going on, and hopefully we get more participants in the next one.
Yeah, absolutely. And if you're interested in hosting any more journal clubs on regards to, possibly vaccines and other medication related topics, then yeah, go for it. I will more than happy to help you host it and see how things go again. So thanks a lot.
No problem, and stay safe out there. Have a happy New Year's, and get your shot if you can.
So this has been recorded. So I'm going to post this on YouTube. But since we looked at the article in particular, I think that I can't make it public. So it's going to be privatized for us in the server. Yeah.
Awesome. Thank you, Bruno.